Welcome to the Lecturio podcast for educators. If you were listening to this, you're likely standing at the front of the classroom or, running a sim lab or leading clinical rounds. So today is really a faculty-to-faculty conversation. We're talking about bridging the persistent gap between educational theory and real-world classroom practice, specifically focusing on how you can help your students build clinical confidence.
As educators, we often hit a wall with traditional training.
Right. The old ways aren't always working.
Yeah, historically, medical and nursing education has been so heavily weighted toward competency. We spend an immense amount of time helping students build a massive knowledge base.
Oh, yeah. Perfecting physical exam skills, all of that.
That's great, teaching them to synthesize disparate pieces of information.
And, we've all seen it firsthand. You have a student who can just ace a multiple choice pharmacology exam. They know every single mechanism of action.
Spot on.
But then you put them in a room where a real patient's blood pressure suddenly starts dropping and they just completely freeze.
Yeah, the application just isn't there.
Right.
Without teaching the actual underlying cognitive architecture, students are going to struggle when faced with ambiguity. They might know the textbooks backward and forward, but they lack that internal framework to recognize when to slow down or when to seek guidance.
Or even how to refine their own mental models on the fly.
Yes. And before we get into the practical classroom strategies of how to actually teach these skills, we need to clearly define what we're talking about here.
Good idea.
Because the literature often treats clinical reasoning and clinical judgment as interchangeable buzzwords. But they are distinct mechanisms.
Okay, let's unpack this, because if we are going to fix the gap, we really need to know what part of the engine is actually failing.
So according to the guide, clinical reasoning focuses on the cognitive process. It's the mental work of gathering data, diagnosing, and formulating a management plan.
So it's the internal logical thought process.
That's it. Clinical judgment, on the other hand, encompasses the real-time decision-making and the prioritization skills necessary for safe patient care.
Got it. So it's the action phase.
Right. Reasoning is the internal logic, and judgment is the external response to a dynamic situation. Also, the NCSBN has actually made clinical judgment assessment a core part of the NCLEX now, so it's highly prioritized.
Well, so if the stakes are this high, 800,000 lives, and these concepts are this critical, why is it still one of the most challenging competencies to teach? Are we just assuming students will absorb these skills via osmosis by following and attending around the wards?
Well, that see one, do one, teach one mentality is really a cognitive trap.
Oh, really? How so?
From a cognitive science perspective, that model fails because it assumes that watching an action somehow reveals the thought process behind it, and it doesn't.
I see.
The main challenge for faculty is that clinical reasoning happens subconsciously in experienced educators. When you, as a seasoned clinician, look at a patient, your brain is processing dozens of subtle cues in milliseconds.
Right, you're chunking information and filtering out noise automatically.
Yeah, you rule out 5 different conditions before you even pick up your stethoscope. So to teach it, you have to forcibly slow down. You have to make your own invisible thinking process visible.
Wow, okay. But mapping out a thought process that you run on autopilot, that sounds incredibly exhausting for a preceptor.
It is a heavy cognitive load, which is why the guide offers specific practical classroom techniques to pull this off without totally derailing a rotation.
Okay, what's the first one?
The foundational strategy is called Think Out Loud. You basically require students to verbalize their decision-making processes in real time during case discussions.
Instead of just accepting their final diagnosis, you force them to narrate the journey of how they got there.
Yeah.
I can see how that stops the guessing game. We have all had a student throw out a diagnosis, hoping it sticks, and you have no idea if they actually arrived at it logically or if they just got incredibly lucky.
Right, it exposes the logic.
But let me step in with a reality check from the wards for a second. When you are on a busy clinical rotation, doesn't making every student verbalize every single thought run the risk of grinding everything to a halt?
It does slow things down initially, yes. But that is a feature, not a bug.
Oh, interesting.
It's a concept we can call deliberate friction. If you don't introduce deliberate friction to expose their thought process early on, they're going to carry faulty logic into their autonomous practice.
That makes sense.
Let's look at a concrete example. Imagine a 68-year-old male patient who presents to the ED with shortness of breath. He has a known history of COPD.
Okay, pretty common presentation.
The student walks in, sees the shortness of breath, notes the COP history, hears a bit of wheezing, and boom, immediately recommends steroids and albuterol.
And on the surface, I mean, that looks like a solid, competent answer based on the most obvious data points.
That is the trap. Because what the student missed was the subtle new S3 gallop on auscultation and the mild jugular venous distension. The patient is actually in acute heart failure.
Oh, wow. So their reasoning completely failed.
It did. And if we rely on gut intuition, we can't fix that. The guide argues we need to move away from intuition and teach students to consciously build what they call illness scripts.
Here's where it gets really interesting.
Yeah.
So an illness script, I used to think of it as essentially a mental filing cabinet where you just pull out the folder for heart failure. But it sounds much more active than that. It's more like the predictive text engine on your smartphone, right?
A predictive text engine is a brilliant way to conceptualize it.
Right.
A seasoned clinician's brain takes a few keystrokes, the patient's age, the shortness of breath, the S3 gallop, and the mental algorithm auto-completes to heart failure.
But the student's predictive text engine is underdeveloped.
Yes. It's a shortness of breath and COPD history, and forcefully auto-completed to COPD exacerbation, just totally ignoring the other data.
So how do we fix that algorithm?
We use frameworks like SNA-PPS.
Okay, SNA-PPS is widely cited, but let's walk through how it actually corrects that specific student's faulty predictive text.
Sure. So SNA-PPS is an acronym designed for active case-based learning. First, the student must summarize the history and findings.
Okay.
Then, narrow the differential, analyze the differential, probe the preceptor by asking questions, plan management, and select an issue for self-directed learning.
Got it. So in our shortness of breath scenario, what happens?
When the student is forced to analyze the differential, the A in SNA-PPS, you, the educator, step in and use positive role modeling.
Meaning I would vocalize my own internal script.
Yes, exactly.
I might say, when I saw the COPD history, my mind immediately went to an exacerbation too. But when I listened to the heart and heard the S3, that data point didn't fit the COPD script, which forced me to pivot my differential toward cardiac issues.
Right. You are modeling the cognitive pivot and doing it in a way that shows humility,
Right.
You're showing them that reasoning is an active, evidence-based process of constant refinement. It's not just this magical intuition you either have or you don't.
But, mapping the thought process is really only half the battle. Once that student successfully reasons through the diagnosis and realizes it's heart failure, they are immediately hit with the pressure of action.
Yes, the action phase.
The patient is still struggling to breathe.
Which brings us to the crisis of clinical judgment.
And clinical judgment is where the stakes reach their absolute peak, particularly in nursing education, where real-time prioritization is just constant.
Right, every second counts.
Dr. Keith's guide relies heavily on Tanner's model of clinical judgment to teach this phase. Tanner breaks down this complex split-second reality to 4 distinct steps.
Okay, what are they?
Noticing, interpreting, responding, and reflecting. Tanner's model kind of reminds me of a slow-motion instant replay in sports. You take a clinical decision that happens in the blink of an eye, and you freeze it into these 4 frames so students can see exactly where they fumbled the ball.
That instant replay removes the shame from a mistake. It turns it into a structural learning opportunity.
Let's apply Tanner to our scenario then.
Right, so did the student fail at noticing? Meaning, did they physically miss the S3 gallop? Or did they hear it, but fail at interpreting, meaning they didn't understand what an S3 signifies in this context?
Or maybe they interpreted it correctly, but they froze up during responding. Like they knew it was heart failure, but didn't know which diuretic to push first.
Exactly. Breaking it down like that gives a faculty member a highly targeted diagnostic tool for the student's brain. You aren't just telling them they're wrong, you're showing them which gear in the machine slipped.
That is so powerful. The guide also mentions using flipped classrooms to support this, along with concept mapping to visually organize the symptoms. But speaking to our audience of seasoned educators, we all know what a flipped classroom is. Students do the reading at home. What's the specific nuance of using it for clinical judgment?
The nuance is how you repurpose that in-person time. If they are learning the basic pathology of heart failure at home, you don't spend seminar time reviewing the textbook.
Right, that's a waste of face-to-face time.
Yeah. You use that hour to induce deliberate friction. You throw them into a case study where the primary diagnosis is a decoy, like our COPD example, and force them to navigate Tanner's model in real time.
I see. And the final step of Tanner's model is reflecting. The guide emphasizes reflective writing to help students recognize their own cognitive biases.
It does.
But let's be honest about the reality of a modern healthcare program. Students are exhausted. They are drowning in reading assignments, lab hours, and clinicals. How do you get exhausted students to actually engage in metacognition rather than just treating it as busy work?
Well, if reflection is presented as a generic summary of their week, it is busy work.
Totally.
The key to powerful metacognition is tying it directly to specific cognitive biases that occurred during a simulation or a clinical day. You have to teach them the vocabulary of their own mistakes.
Let's get some concrete examples of those biases because they are really fascinating.
Sure. Let's look at anchoring bias. Anchoring is when a clinician locks onto the first piece of clinical data they receive and ignores subsequent clues that contradict it.
So in our scenario, the student anchored on the COPD history.
Yes. Another common one is premature closure. This is the tendency to stop the diagnostic process as soon as you find one plausible answer.
Right, so the student found wheezing, decided it was COPD, and essentially shut the door before fully evaluating the cardiovascular system.
That's it. So a reflective writing assignment isn't a diary entry about how they felt. It's a prompt that asks, identify one moment today where you exhibited premature closure. What data did you ignore? And how will you adjust your illness script for tomorrow?
Oh, I love that. It becomes a survival tool for their own intellect.
It really shifts reflection from a passive chore to an active diagnostic tool. But acknowledging the brilliant design of Tanner's model and SNAPPS brings us to a massive reality check for the educators listening.
Oh, here we go.
Implementing these frameworks deeply is incredibly tough.
It's a tall order. We're asking faculty to teach a highly complex cognitive architecture, which requires immense patience, and they were never really taught how to teach this in the first place.
The source material is very clear-eyed about this. It outlines 3 major real-world roadblocks that medical, PA, and nursing programs face.
Okay, what's the first one?
The first is a profound lack of curricular time. The modern syllabus is already bursting at the seams just trying to cover the required competencies in board prep.
So finding room to slow down for deliberate friction feels like a luxury.
It really does. And the second roadblock is limited faculty expertise. And this isn't a knock on faculty. You can be a world-class diagnostic clinician, but diagnosing a patient is a fundamentally different skill set than diagnosing a student's flawed logic path.
Oh, 100%.
Sure.
It requires specialized faculty development that many institutions simply don't fund.
Yeah. And that leads directly to the third barrier, the absence of standardized assessment methods.
Meaning a lack of objective tools to evaluate their progress.
Yes. If you don't have objective tools to evaluate a student's progress in reasoning and judgment, it becomes entirely subjective. How do you consistently grade a student's internal cognitive process?
It feels like an impossible bind. We know they need this deep structural coaching to prevent those 800,000 adverse outcomes, but there is zero extra time in the syllabus, and educators are already stretched to the breaking point. How do programs solve this without just piling more work onto the educators?
Well, the answer lies in scalability. And according to the guide, that means strategically leveraging technology. We have to introduce digital tools that take the heavy lifting of case generation and assessment off the individual faculty members' shoulders. The source specifically highlights platforms like NEJM Healer and simulation-based learning software.
Let's look at NEJM Healer. How does a digital platform actually teach reasoning better than, say, a paper case study?
It creates structured, interactive environments where students practice clinical reasoning in realistic scenarios at their own pace. But the key is the massive data collection happening in the background.
So they're interacting with it, and it's tracking them.
Yes. Students log in, gather patient data, generate their own problem representations, and build differential diagnoses step by step.
So what does this all mean? It sounds like we are giving them a high-stakes flight simulator.
That's a great way to put it.
They get to step into a virtual clinical environment, and if they anchor on a decoy diagnosis and make a catastrophic judgment call, they crash the virtual plane, figure out their cognitive biases without any actual patient risk.
The flight simulator analogy is so fitting because of the feedback loop. The benefit for the student is immediate, detailed feedback.
Right, they don't have to wait.
No. If they miss a crucial cue in the patient's history, the software catches it instantly. It provides expert insights through text, audio, and graphics right in that moment, explaining the pathophysiology of the cue they missed.
They don't have to wait a week for a preceptor to grade a concept map just to find out they were wrong.
Exactly.
And what's the benefit for the faculty? Because we were just talking about the lack of standardized assessments and educator burnout.
This is where it radically shifts the educator's workload. These platforms provide standardized performance data through detailed back-end dashboards.
Oh, nice.
As an educator, you don't have to manually grade dozens of complex reasoning essays. You log in, look at the analytics, and instantly see that, hey, 60% of your cohort fell for premature closure on a respiratory case.
Wow, that is a total paradigm shift. Instead of walking into a seminar and delivering a broad lecture hoping it covers the gaps, you are practicing precision education. You can just say, all right, everyone, the data shows we are collectively struggling with interpreting S3 gallops in the presence of respiratory distress. We're going to spend 15 minutes unpacking just that specific failure point.
Yes. And furthermore, these platforms offer immersive real-world scenarios that cover a massive range of core diseases, guaranteeing standardization of experience.
Because in a live rotation, a student's exposure is entirely dependent on who actually walks through the hospital doors that month.
Right. They might go their entire rotation without seeing a specific critical presentation. Technology ensures every learner gets reps on the vital cases, leveling the playing field.
So, wrapping all of this up, the major takeaways for you, our fellow educators, are clear. Clinical reasoning and clinical judgment cannot be left to chance or osmosis. They really must be explicitly, deliberately taught by making the invisible cognitive process visible.
Right. And to briefly summarize our roadmap today, competency is merely the foundation. By utilizing frameworks like SNF-PPS to correct reasoning, applying Tanner's model to dissect real-time judgment, and consciously building evidence-based illness scripts rather than relying on intuition, you set your students up for safe, autonomous practice.
And crucially, you do not have to do it alone on a whiteboard. By integrating technology-driven tools, you can provide that scalable, standardized feedback that builds expert-level confidence in your students while actively preserving your own time.
Absolutely vital.
To that end, if you're feeling the pressure of these curricular roadblocks, we strongly encourage you to schedule a demo with Lecturio. You can see firsthand how digital tools, specifically platforms like Angular and SimTutor, can seamlessly support your institution, save your faculty countless grading hours, and fundamentally elevate your learners' readiness for real-world care. Thank you for joining us on this deep dive. We will catch you on the next one.